erudite discussions. This enlightened view of epilepsy will begin with a definition. Now these are being modified as time goes on, but the standard classical definition of epilepsy involves the presence or occurrence of two or more unprovoked seizures, meaning that if there was something that could have caused a seizure, such as marked sleep deprivation, alcohol withdrawal, etc., that would not be considered unprovoked. Now, the newer definition, which is being proposed by the International League Against Epilepsy, which is not to be confused with the Justice League of America, can now include patients with a single unprovoked seizure if those patients are at high risk for recurrence, because about 40 to 50% of those people will have recurrent seizures. And here is that list of factors which would take someone with a first unprovoked seizure and place them at that high risk category such that they would be considered to have epilepsy despite having only one unprovoked seizure. I would like to give a shout out to my future stepson, Dr. Dane Mackey, for this idea of putting in the mnemonic in the actual slide itself. And so you can see that focality on examination, on seizure presentation, on imaging is a large risk factor, probably the largest. Others include family history, history of neurosurgery, a diffuse neurological disorder specifically or particularly in the young people, in which they may have evidence for a metabolic disorder and diffuse cortical dysfunction, previous history of meningitis or encephalitis or both, a traumatic brain injury or a stroke. Again, all of these factors have in common are that they've caused a previous injury to brain such that there is an area of potential scarring of the cortex and or electrical instability. Looking at these risk factors, focality is actually a reference to Foucault's pendulum, which is an actual physics concept, but also made famous by Umberto Eco in 1998 by a book of the same name. Of course, everybody recognizes Dr. Eco as the semiotician, semiotics, the study of signs and symbols from the University of Bologna. So you can remember this mnemonic by either you found METs, but with epilepsy that's really not very appropriate. So you can think of finding, I found my toes if you are a baby, or as an adult you can say I found my tush. Any way you need to remember this is very useful. The classification of seizures is very important in regards to eventual specific treatments, and they can be divided into generalized versus focal seizures. Within the category of generalized seizures are absence seizures, myoclonic, and primarily generalized tonic-clonic seizures. Within the category of focal seizures, there are the focal seizures without altered awareness, focal seizures with altered awareness, or focal seizures that lead to tonic-clonic seizures. Now, the focal seizures with altered awareness was the seizure type formerly known as complex partial seizures, but that was too simple, so they had to make a much longer term. Within the leading to tonic-clonic category would include patients with a focal onset seizure, which then secondarily generalizes, such as a Jacksonian march, in which one part of the body is involved, and then there's gradual involvement of adjacent portions of the body as the electrical impulses travel through the motor homunculus and cause those seizures to generalize. A few notes about epidemiology of epilepsy. About 10% of Americans have had a solitary seizure at some point during their lives, but of course they are not considered to have epilepsy. About 3 million Americans, or 1 in 26, do have epilepsy. The peaks of onset of epilepsy are both early in life and then later in life. Early in life as the manifestations of metabolic disorders, etc., are present, and later in life as the results of various brain injuries, as we discussed previously, are manifest. Many of these people who do have epilepsy, unfortunately, are not seizure-free, and therefore there is a great toll on their quality of life, since they may have difficulty with employment, and they may even need caregivers. The differential diagnosis of epilepsy is fairly extensive and can be divided into both non-physiological and physiological events. It's been estimated that of all patients that are referred to an epilepsy monitoring center, at least 20 and up to 50% of those patients are having non-epileptic events. So the beginning of the differential are those other neurological conditions which can cause transient neurological deficits, and of course those are TIAs and migraines, but those are fairly readily distinguishable. The non-physiological category includes the formerly dubbed pseudo-seizures, now with a different terminology, and I go into more detail on that in another topic, another talk. Amongst the physiological events which can mimic epilepsy, most notably are the cardiac events, syncopal and other cardiac disorders, and in which case you have to go over in detail in history what the aura or pre-ictal event, what did the ictus itself consist of, and what was the post-ictal phenomenon seen, and even then cardiac events may not be distinguishable from epilepsy, particularly in the category of convulsive syncope, in which there are in fact some myoclonic jerking or actual tonic-clonic type activity which occur as the result of the cardiac event, cerebral hypoperfusion, and possibly the inciting of a seizure type episode due to that. Also within the differential are sleep disorders, given that many people with epilepsy may have seizures only during the night, and so it's difficult to distinguish whether it was a sleep problem or a seizure itself. Now, sleep disturbances can include parasomnias or cataplexy, but in general, with a good history, they're distinguishable from seizures, but at times video monitoring is going to be necessary to more definitively exclude those possibilities. Evaluation of a patient with potential epilepsy. Certainly the history is of paramount importance, but unfortunately the patient may not be able to provide the history if they're having their seizure, so it's incumbent upon the physician to seek out anybody who's been a potential observer or witness of a seizure event and get as many details as possible. Now, the EEG has been the standard for evaluating the possibility of seizures. In order to maximize the yield of any individual EEG, The EEG should be obtained under conditions of the patient being sleep deprived. One should record sleep and perform the standard activating procedures of hyperventilation and photic stimulation. Unfortunately, even under optimal conditions, patients with epilepsy may have a normal single EEG about 50% or more of the time. The diagnostic yield may depend or does depend on the seizure type, so that the sensitivity and specificity of the EEG depends on the seizure type. For example, a generalized absence seizure under optimal conditions will generally yield a positive or abnormal EEG, whereas a focal onset seizure, particularly if it's of extratemporal origin, may not ever show an abnormal surface EEG. Given the above considerations, if the diagnosis of epilepsy is seriously entertained, a solitary EEG doesn't rule it out. You can consider doing up to 3 EEGs where there's an 80 to 90% chance of getting an abnormal study, or even performing a 24 to 48 hour ambulatory EEG. Another useful tool in the epileptologist's armamentarium is the performance of a so-called video EEG monitoring, in which the patient is admitted to the hospital so that video to record the patient's clinical behaviors along with simultaneous EEG monitoring can be obtained. The indication for this type of procedure is when a person has recurrent events that have eluded all best intent of outpatient evaluation, including non-diagnostic or ambiguous EEG results. This video EEG monitoring allows one to determine the seizure type, and if the patient has had intractable epilepsy and is being considered for seizure surgery, this procedure is performed so as to help localize the seizure focus so that they can potentially have that surgically removed. Of course, this is a very labor-intense and expensive procedure, and so that needs to be taken into account when ordering this. And finally, and congratulations for arriving at this slide, a few words about the imaging evaluation of a patient with suspected epilepsy. Obviously, MRI scan is the test of choice. It can actually be done without contrast unless previous studies or the non-contrast MRI scan indicates the presence of some sort of vascular anomaly, an AVM, a cavernous hemangioma, etc. But otherwise, you don't need to have contrast because the major lesions that you're looking for are visible even without contrast, and in particular, the presence or absence of mesial temporal sclerosis is easily found invariably with a non-contrast scan, and you can read these weird radiological terms, and if you're expecting me to explain what the hell they mean, you can forget about it.